Mental Health, Chapter 23. This chapter talks about eating and sleeping disorders. I'm going to skip through the objectives. So first, let's review body image. So body image is it's a person's collection of perceptions, their feelings and behaviors that relate to the size of their body and the appearance of their body. People with positive body images tend to express self-confidence, whereas people with negative body images often find themselves experiencing shyness and social isolation. And, there's a lot of current trends still in the United States that lead to eating disorders. So society still does put a lot of value, a lot of focus on being thin. And this is often used as a measure of attractiveness. Whereas it used to be years ago, if you were overweight, it meant you were rich and upper class. But that doesn't really exist anymore. Now, eating disorders. So an eating disorder is an ongoing disturbance in behaviors that are associated with eating. 30% of all adults believe that their actual weight is greater than what their desirable weight is. And many people are forever in pursuit of the perfect body. So the eating disorders will start with anorexia nervosa. So with anorexia nervosa, the individual does not maintain a normal body weight because they have an intense fear of becoming fat. And approximately 90 to 95% of people with anorexia nervosa are female. These patients refuse to gain weight, and the whole eating disorder really has been found to be a part of their strategy to solve a deeper psychological problem and to maintain some form of control. And control is actually really normally their main issue. Classic description of a person with anorexia nervosa. First off, the average age that this is diagnosed is the age of 17. These people or these clients tend to be tense, very alert, hyperactive, rigid in the way they go about their daily life. And again, it tends to be more women than men. Although, you know what, there are more than 1 million men who are diagnosed with it per year, so it's not strictly a female disease, but 90 to 95% of people who have anorexia nervosa are female. So when these clients present to the healthcare system, they are now involved with a life-threatening disorder. And to this person, the absolute smallest gain in weight is seen as a threat and a failure in their self-control. So they feel that they are losing control. These clients have a food phobia. And very often they'll go ahead and prepare elaborate meals and eat like maybe one bite of it and push the rest around the plate. We also have found sometimes there are often other obsessions going on at the same time, preoccupations with cleaning or exercising. So the criteria to actually make a diagnosis of anorexia nervosa can be found on box, I believe it's 23-1. Or, yeah, 23-1. So the diagnostic criteria includes a refusal to eat that causes a person to have a significantly lower body weight, all right, greater than 15% below normal. And even though this person is underweight, they have an intense fear of becoming fat. They have a distorted significance placed on their body weight, and the person just continuously feels fat and sees themselves as being fat, even though they are significantly underweight. And there is an absence of at least 3 menstrual cycles in a female who has been previously menstruating. and there is an ongoing lack of recognition of the seriousness of this problem. Now, the clinical presentation, well, these patients show, obviously when they are introduced to the mental health care system are significantly underweight. And there's a very high mortality rate that is associated with anorexia nervosa. And a lot of this is due to complications of starvation, like dehydration, loss of critical muscle mass, electrolyte imbalances. A lot of these clients experience cardiac arrest. And again, a lot of this is due to malnutrition, electrolyte imbalances. And a lot of these patients also tend to be suicidal. So the death rate associated with anorexia nervosa disorders is much higher than it is for any other mental illness. Now, if we were to talk about bulimia, bulimia is a disorder of binge eating and the use of inappropriate methods to prevent weight gain. And these patients will binge and purge. People who are diagnosed with this are often found to be young, white, middle class, and upper class women. And perfectionism is important to these patients, and it contributes to the maintenance of bulimic behaviors. Now, so I read a book one day about a young woman who was experiencing bulimia, and it was a story about her family. And the family, what they ended up doing was after dinner, the young woman wasn't allowed to be in the bathroom alone because they were afraid she was vomiting. So they would watch after dinner, and she would just go into her room and shut the door. And they were very happy because they figured, okay, great, she's getting better. She just ate a whole dinner. She didn't vomit. We're good. But in reality, the young woman had a captain's bed with a storage drawer underneath it. And one day her parents went into her room and they opened the storage drawer and it was filled with sealed bags of vomit. So this girl was so meticulous about keeping her disease secret that she would go to her room, shut herself in, vomit into a bag, and put it underneath her bed. So again, these patients will eat, but then they go ahead and they will vomit to so that they don't gain weight. And a lot of times when they are binging, what they will binge on is cake, donuts, and sweet things. Okay, that's if they are binging. Okay, now the criteria for diagnosing bulimia: recurrent episodes of binge eating, which is above and beyond healthy eating. And as I said, when people binge eat, a lot of times it's cake, donuts, sweet things that they ingest. Binging is followed by recurrent inappropriate behaviors to prevent weight gain. And these behaviors include either inducing vomiting, misusing laxatives, enemas, diuretics, so that their body won't retain any weight. A person who has bulimia has eating binges at least twice a week for 3 months. And they have excessive emphasis placed on their body shape and weight when they're talking about their self-esteem. So doing a 360-degree or 180-degree turn, whichever it is, completely turning around. Now we're going to talk about obesity, which is defined as an excess of body weight. Now, mild obesity is somebody who's 20 to 40% above their normal weight. Moderate obesity is someone who's 41 to 100% over their weight. And severe obesity, which is also known as morbid obesity, this person is greater than 100% over their normal weight. And it's a result of too many calories consumed, or not enough calories burned. Now, it has not been established that obesity is consistently associated with mental health or behavioral problems. So other disorders, other eating disorders, pica. And pica is the persistent eating of non-food items that lasts for more than 1 month. There's no really defined cause. At times it's been thought that pica can be associated with deficiency in zinc or iron. But a person experiencing pica has cravings for substances such as clay, laundry starch, insects, leaves, and pebbles, This person still eats and enjoys normal food, but they also crave these other substances as well. And we also talk about rumination disorder, which is the regurgitation and re-chewing of food. So this is someone, and when it's seen, it's normally seen in childhood, but it is fairly uncommon. The person brings up partially digested food. They make themselves vomit partially digested food. They bring it up into the mouth. And then they re-chew it and either swallow it or spit it out. So, guidelines for intervention. Well, the main therapeutic goal for all eating disorders is to establish behaviors that promote health for the client. Okay. With the treatment and therapies, we want to stabilize any existing medical problems. And this has to take the highest priority. A lot of these people are very physically sick by the time they enter the mental health care system. We want to help them reestablish normal nutrition and eating patterns. And the goal for anorexia nervosa is to encourage the patient to eat voluntarily. Okay, that's the main goal. If someone has anorexia nervosa and is in treatment, the treatment goal is going to be to have them eat voluntarily. Okay, not with someone standing there saying you have to eat this, but voluntarily. And the other thing that we try to do is resolve the psychological and emotional issues that underlie the eating disorders. So the first thing we have to do is get them physically healthy. And then the next goal would be to get them to eat voluntarily. And then the third thing is to approach the underlying emotional causes. So clients what we do is we help to identify how it is that they use food to provide comfort and reduce their anxiety. Like, what does the food do for them? Clients are helped to replace a distorted body image, and they are taught problem-solving skills. Many are also treated for depression and anxiety. Now, there is actually a care plan on page 270. If you get a minute, just take a look through it. It talks about some of the things, and this care plan is reflecting the care for a 15-year-old who's 20 pounds underneath her usual body weight. And I'm just going to say the interventions, again, with mental health. Number one, we'll establish trust, do a nutritional assessment, help her identify the consequences of her eating behaviors, monitor her physical status daily, and explore other ways to achieve control over the parts of her life that are causing distress. So if we talk about sleep disorders, a sleep disorder, which is also known as a sleep-wake disorder, your book refers to it both ways, is a condition or a problem that repeatedly disrupts an individual's pattern of sleep. All right, and we're going to talk about how do we diagnose these things. Well, we do a history and we do a physical exam. But then there's many tests that can be looked at. A polysomnogram monitors the electrophysical responses during sleep. Okay, and it includes the three terms that I'm going to go through. There's the electrocephalogram, which is an EEG, and this measures brain waves and activity. There's also an electromyogram, which records muscle movement, and the electrooculogram, which records ocular eye movement. Okay, so all of these three are all measured during a polysomnogram. And this gives us a look into how well the client is sleeping. Dysomnias are abnormalities of the physiological mechanisms that regulate sleep and wakefulness. Okay, so insomnia. Insomnia is accompanied by, it presents with a lot of physical and mental alertness when it's bedtime, sleepiness during the day, and then, so the person doesn't sleep much at night, they're sleepy during the day, and then they start and worry about, am I going to sleep tonight? Am I going to sleep tonight? And it starts to build anxiety, and the person is so anxious that they can't sleep. And they can't sleep, so then they're sleepy during the day, and they start and worry about, am I going to sleep tonight? It's a vicious circle that can go on and on. But it's defined as the disorder of falling asleep or maintaining a sound sleep. Now, there's also primary hypersomnia, which is excess sleepiness that usually begins between the ages of 15 and 30. Now, narcolepsy, the primary hypersomnia progresses over a period of weeks and months and then will become chronic. So people with this disorder will sleep 8 to 12 hours at night, wake up still tired, groggy, not refreshed, nap for at least 1 hour during the day, and feel unrested. And it becomes very hard for these people to meet their work and social obligations. They have decreased concentration. They start to do things like fall asleep while driving, no memory of carrying out certain tasks. Okay? And people with narcolepsy. So this is a condition which the individual has repeated attacks of sleep. People with narcolepsy can actually fall asleep in the middle of a sentence. And the individual may experience cataplexy, which is a sudden episode of muscle weakness and loss of muscle tone, which can last seconds to minutes, and inappropriate rapid eye movement. Okay, and when this occurs, patients can have dreamlike hallucinations. Now, there's also obstructive sleep apnea. And obstructive sleep apnea is periods of apnea that waken the individual. The person stops breathing during their sleep. And a lot of times it's due to a partially obstructed upper airway. Okay, repeatedly wakes the person up. Person can be apneic for a few seconds to as long as 90 seconds. And then that person will moan or grunt for air, take a few gulping snores, and go back to sleep until their next period of apnea. Untreated sleep apnea has been associated with cardiac arrhythmias, strokes, hypertension. It's found to do very unhealthy things. So we do try to treat it, and mostly the treatment of choice is to use a CPAP mask at night. And then there's the circadian rhythm sleep disorder. And this is a persistent pattern of sleep disruption that results from a mismatch between your body rhythms and environmental demands. Okay, anybody who has ever worked night shift understands this completely. So you have your circadian rhythm all set so that you're sleeping at night and you're up all day, and then all of a sudden you try to flip it around. And a lot of patients end up having sleep disorders because they're trying to fight their circadian rhythm. And then there's restless leg syndrome. And this is also known as nocturnal myoclonus. Nocturnal myoclonus. And what it is repeated brief jerks of the arms and the legs that occur every 20 to 60 seconds at the beginning of sleep. Okay, disagreeable sensations, tingling, itching, that occur when an individual is falling asleep, but also brief jerks of the arms and the legs. Parasomnias, sleep disorders that are characterized by abnormal behavior or physical events during sleep. So first one we're going to talk about is nightmare disorder. So this is a person who experiences repeated frightening dreams that lead to abrupt wakening. And then there's patients who have sleep terror disorder. These are reported nightmares and abrupt wakenings, but accompanied by a panicky cry or scream and intense fear. Okay. Person doesn't wake up easily from this. It's hard to wake them up, and they have no memory of it once they're awake. It occurs usually once a night, and it is characterized by patients who are experiencing intense stress. So sleep terror disorders, patients who have nightmares wake up screaming with a panicky cry, and a lot of times these patients are experiencing some sort of an intense stress. And then there's sleepwalking disorders, episodes of complex motor movement during sleep. Sometimes these patients will be walking around with a blank stare, and it's difficult to wake them up at that time. When you do wake them up, they may be very confused, and chances are they will not remember any of this. And people who experience this disorder, it's normally seen somewhere between the ages of 4 and 8 and peaks at about the age of 12. Now, your book mentions, but the PowerPoint doesn't mention, nocturnal sleep-related eating disorder. And this is patients who will get up and binge eat during their sleep. They don't remember it. They eat a bizarre selection of high-calorie food, and they also eat non-food things such as cleaning products, pet food, and cigarettes. So what do we do for intervention? Well, we try to get our patients to maintain a regular sleeping routine, which isn't always possible, but this is what we advise them to do. We try to promote comfort, control physical disturbances. Everybody needs a nice, quiet, restful environment to sleep in. Now, sleep hygiene strategies, again, a regular bedtime and wake-up time, exercise daily, schedule time to wind down and relax before bed. Try to avoid worrying when you're trying to fall asleep. Try to guard against any sort of nighttime interruptions, heavy window shades, earplugs if you have a noisy partner sleeping in the room with you. Maintain a cool temperature in the room. Excessive hunger or excessive fullness can interfere with sleep. Avoid large meals before bed. Avoid caffeinated drinks or excess fluid intake or stimulating drugs or excess alcohol in the evening. Avoid excessive daytime napping. Do not eat, read, work, or watch television in bed. Maintain a reasonable weight and get out of bed and engage in other activities if unable to fall asleep. And with that, I was going to say something about go take a nap, but it just wasn't going to come out funny. That's the end of this chapter.